This is the Owens Recovery Science Podcast.
Kyle, Zach, what's up, man? Welcome back. We have another amazing Owens Recovery Science Podcast. Feels like it's been a minute since our last one. I think Lee Winchester was our last one last month. This one is going to be badass because we have our favorite Welshman back on the call, Luke Hughes. I was going to come up with a nickname. Oh, Luke Drake Hughes. He's been called the Drake of blood flow restriction.
He puts Shout out to Brian Goonan for that nickname.
Yeah. He's the whitest Drake you've ever seen in your life, man. So anyways, all the way from Wells, it's nighttime there. He's about to have some football here in a minute. Okay, let's get into this real quick though, Luke. Football.
Oh, hey guys.
Sorry, Luke. Welcome.
Hey guys.
I was waiting for Luke to pop in with an "In My Feelings" dance, like out the car, like they do, you know.
So, Luke, Ted Lasso, you guys love it or not over there? What do you guys?
Yeah, it's quite an interesting watch, to be honest. I'm
Really?
a few episodes in, but fortunately we don't have anyone like that coaching us at football. And hey, Johnny, I thought I was your only Welshman as well. What do you mean the favorite Welshman? I thought I was the only Welshman.
We got to leave room for future, Luke. I mean, we're thinking long term here.
Catherine Zeta-Jones, I guess that's my favorite Welsh person, and then you're next. Did you know I'm Welsh? That's my family history. I mean, I'm Texan, but I did the stupid ancestry thing for a Christmas gift. So, now they have my DNA like all over the freaking internet, and you can never kill anyone because, my DNA is out there everywhere. But it came back and it's almost 100% Welsh, Luke.
Wow.
Yeah.
Very privileged. Very, very lucky. I didn't know Jay-Z was Welsh.
Yeah. Well, if you Google my name, which not that I do that or anything that much, but if you Google it,
it just goes to the IMDb page.
No.
The autocorrect. That's all it is.
It used to be I was third, so it was this commercial real estate Johnny Owens in Oklahoma, and then I was in third behind him. I whooped his ass now, so he's way down, and I'm number two. You know who's number one? A Welsh boxer named Johnny Owens, who died in a fight. He had like one loss and he died. And so I looked up this guy's story to try and, because he, apparently, do you know him, Luke? Is he famous over there? Johnny Owens, the boxer?
No, I did not know him before. That's the first I've heard of it.
You fake ass Welshman. He's a hero over there.
Come on, Luke.
I've just Googled this, and he died 12 years before I was born. So that's probably why. He's old.
You gotta keep up with your history. You see the picture
have like a
guy?
statue
Look
or
at
something?
the freaking ears on that guy. They're huge. So I looked up his background. Listen to this of how he died. This is on Wikipedia, so it's true. This is when he got to the hospital after he took the punch to the chin. The neurosurgeon in charge of Owens revealed how they discovered that Owens possessed both an unusually delicate skull and a strong jaw. How the hell did they figure, he's got, is that a thing, Luke? You guys have delicate skulls?
We're just a delicate race in general, I think.
And so as a result, Pintor's punch inadvertently pushed Owens' jawbone through the back of his skull into his brain. I mean, Jesus Christ.
Jesus,
anyways, that's my ancestry.
That's very depressing. Hopefully we can boost you up to number one, Johnny, so people don't have to read that.
I mean, 12 years ago, the guy with the weak skull, and he still beat me out. We'll get him.
So, Luke, you might need to wear like a face mask or something to play soccer. Then, if
it's football.
Oh,
football.
I'm
Football.
sorry.
Thanks, Zach. You took the words right out of my mouth.
Football.
All right, so we got
all that matters to us is the Oklahoma-Texas game next week when we get to talk trash to Jeremy Lineker once.
Yeah, my wife wants to have a garage sale next Saturday. I was like, you're kidding me, right?
No way.
Yeah, it's on. So anyways, we're having Luke back on. He's a good friend of ours and been on the podcast before because he's got a new paper out. Is it actually out yet, Luke?
Yes, it's out. It's in press on Journal of Applied Physiology website. Yeah.
Okay. Journal of Applied Physiology. If you remember our other podcasts or just know the BFR literature, Luke's kind of leading the charge here of trying to figure out what the mechanisms are for blood flow restriction and the potential pain relieving benefits, the analgesia of it. And so the title of this one is Aerobic Exercise with blood flow restriction causes local and systemic hypoalgesia and increasing circulating opioid endocannabinoid levels. So I kind of butchered that, but it's building on what Luke looked at in the past, was that if you do blood flow restriction resistance exercise, especially at a higher pressure in the lower extremities, so 80% limb occlusion pressure, they saw a pretty nice reduction in pain in healthy individuals, as well as a systemic or remote effect. So they had pain in the upper trapezius, even though you did it on the leg. They had a 24-hour effect. If you did BFR, I think I'm getting it all right. So this was kind of a repeat of that same kind of trial to see if aerobic exercise carried the same benefits. Is that pretty accurate there, Luke?
Yeah, Johnny basically just banged on.
Podcast over.
We good? Okay. Yeah. So thanks,
Okay.
Luke. We'll see you later.
Thanks for tuning in, everybody.
Be sure and
Cheers, guys.
watch old videos of Johnny Owens boxing. So anyways, Luke, you want to go into what your design was here and what your thoughts were here?
Yeah, thanks, Johnny. And it was a nice overview to start with. So as you said, we basically followed on from the previous paper in Journal of Applied Physiology, where we looked at resistance exercise. And we decided to look at, does the same thing happen with aerobic exercise? So we designed a similar study, like a randomized crossover trial, where we had 4 different exercise conditions. So they were all cycling exercise. The individuals cycled for 20 minutes. And we based that off one of Jeremy Lonicki's training studies, actually, where they compared BFR cycling versus high intensity cycling over 6 weeks. So we took a protocol that had been shown to be effective for improving muscle size and strength with aerobic exercise, and we thought, right, can it have an impact on pain for individuals as well? So 4 different exercise conditions. So it was low intensity aerobic exercise, and the intensity was set at 40% of their VO2 max. So we did all the assessments beforehand so we could prescribe the intensity. And then there was 2 other, so that was the first one. There was 2 BFR conditions. So they also performed cycling at 40% of VO2 max. In one of the sessions, it was done with BFR at 40% of LOP. And in the other session, it was BFR 80% LOP. So we were trying to capture that what we think is that effective range of BFR pressures within the literature. And it's what we looked at in the previous paper as well. And then, of course, we had our comparison to high intensity exercise. So that was performed at 70% of VO2 max. And as I said, it was just 20 minutes of continuous cycling. For the BFR groups, we did like a BFR cycle. So we had 3 minutes of inflation, followed by 1 minute of deflation. And then that totaled 5 cycles in 5 cycles in 20 minutes. So we were, as you guys know, there's a few papers that have said they apply BFR continuously with aerobic exercise. We tried that in some pilot testing, and man, that was brutal.
I knew when I saw this that it's 20 minutes that it had to be interval.
Yeah. So I honestly, I think I made it to minute 7.5, and like I'm pretty much about to fall off the bike. So we decided to go with some cycles. So it was about 5 cycles for 3 minutes inflation, 1 minute.
Did you see it was just as hard at 40%? Because I don't know if we've ever cycled that low when we've done it.
It felt a bit easier, but still, I think no more than 10 minutes I was going to be doing straight with 40% even. Like it's pretty brutal. That might just be me. There may be people out there who can do it, but
Luke, y'all's bike, was it an upright bike or was it recumbent?
Upright bike.
Upright.
Okay. And Luke, you tested that. You measured LOP in the position of exercise, right?
Yeah, we did. We measured LOP with them pretty much on the bike, just with the cuffs on.
That would certainly that 40%.
Yeah, so that would raise the 40% compared to if we did it, say, supine. And then with that, one of Ben's questions that he was wondering was, why not measure supine? Why did you guys choose? Because you did that in your ACL paper as well. You measure them in a position on the leg press, right?
Yeah, correct. It's a good question. So the reason we did that was based off one of the studies during my PhD, where we found that body position affected the occlusion pressure. So as every researcher's worst nightmare happened, and as we were doing the study, Sealjacks et al. Published the same paper as we were doing ours.
Exactly.
So they essentially showed first that LOP was higher in a seated position compared to a supine position. And we'd looked at supine, seated, and upright. And based on that, we saw considerable difference in LP between like supine and standing. So we kind of said from that, if we want to be accurate in prescribing pressure from like a safety and effectiveness point of view, that we were going to do it in the body position for exercise.
Now, without getting too far off topic here, with that just being the single exercise, probably okay to do that. But what do you think if you would do like in the clinic, right? Because we would do multiple exercises in varying body positions. I think the one thing that came out of your paper that you did on different body positions, showing differences in limb occlusion pressures, and Sealjack's paper really showed the same thing. That I would say the concern is going to be, if you're going to do it in the position, whether it's like a squatting position, you're going to do it standing. But then if you would have them do a straight leg raise, you potentially could put that individual at full occlusion. And that's the big concern that I always tell people when that question comes up. What do you think about that?
Yeah, it's a great question. So I suppose that was kind of the rationale for the kind of conclusions that came out of the study. We said that if you measured someone standing and then they did a horizontal leg press, there's a chance of over occluding them.
Yep.
So I think, like, clinically, when we had our ACL patients in that previous study, obviously there's not a lot of time. So I would say that if you get one measurement early on at the beginning of the session, just to stick with that for the rest of the session. But typically, I know that's how other people are doing it. So would maybe get it in. I know some individuals at different clinics who are doing it in supine and then using that even for standing exercises, because they're more concerned with ensuring that they get effective stimulus, but not over occluding. They're more concerned with not over occluding than maybe slightly under occluding, especially in those like early post-op phases. So a lot of individuals just do supine and then use that LLP value for the rest of the session. And
then just this last thing was the other thing I point out too was both your paper and the Sealjack's paper. They were just acute studies. They were literally, we measure this and we see a difference in body positions versus carrying out the training program in those, across pressures in different positions. Right. So we don't truly know if we just measured in supine, are they truly underdosed if we do a squatting exercise or something along those lines? The one thing that we do know is when we do it in supine, it seems to be an effective enough stimulus at 80% limb occlusion pressure to get the carryover we need.
Yeah, absolutely. We see that for the papers out there now. And, as you said, it's an acute study. So they were just, those conclusions we made that this potentially could have an effect over a training program.
Yep.
We see 80% limb occlusion pressure measured in supine being effective. We measured it with them horizontal, and it was effective in our ACL study. So yeah, I think the important thing really, the training studies in LLP, the underlying thing is that we just measuring it every session, as we say.
Yep.
And that's why devices that can do that automatically for you quickly, in under a minute, are ideal, especially in a clinical setting. And I don't know if we spoke about this before, guys, but we haven't published this data yet. I'm gonna have to try and dig that out. But over the course of our ACL study, the 8 weeks, we saw basically a gradual increase in LLP across the study, which makes sense because we saw hypertrophy. So again, just supporting that rationale for measuring it every time.
When I get it in standing, man, it's crazy how much harder and higher it is. I mean, I did some split squats the other day. I was like, Jesus, I think I want to do this supine because
it's
my
way
LLP
different.
was in the high 200s.
It's for me, it's really high, and becomes whenever I've tried to measure it in standing and do like bilateral squatting exercise, it's unbearable, even just like a body weight sometimes. I find it really, really difficult. I just don't think clinically it would be hard to do that. But we were just trying to reiterate the importance of controlling that occlusive stimulus as best as we possibly can.
Sure. So we were talking about a pain study. I forgot where we are now.
I think we were talking about the different pressures, 40 and 80. Yeah.
Freaking Ben's not even on the call, and he sidetracked us with his question.
I was just wanting Johnny to try to pronounce the endocannabinoid thing that y'all studied.
I can't ever get that right, man. Can we just call
it the arachnophobia gene or something? Is all I can tell.
2AG. I don't think I've ever said it out loud in full.
I don't know. I don't know that you should ever try. It sounds, I don't know what it is. It's terrible.
So, okay, 4 conditions: low pressure, 40%, high pressure, 80%, interval bike, which I think is, if you're going to do bike, probably more than steady state, especially with newbies. I think interval protocol is the best way to go because you don't make your people freaking bonk and pass out. A high intensity, group as well, and a low intensity. Right. Okay.
Yeah, that's where we were up to, and the BFR was intermittent. You know, they cycled continuously for 20 minutes. We just kind of inflated and deflated the cuff in those cycles, so they didn't stop and have a rest period. But yeah, so we did that, and then we kind of replicated our previous study where we measured pressure pain thresholds, so as our marker of pain sensitivity, using a mechanical handheld ergometer. So we did that pre-exercise and then post-exercise. And then we also took our venous blood samples again, so we could look at our pain markers. And then we took that plasma, froze it down, and analysed it at a later date. So in a nutshell, what we found essentially is with the low intensity aerobic exercise group, so 40% VO2 max with no BFR, there essentially wasn't any changes in pressure pain thresholds. And when you look at some of the exercise-induced hyperalgesia literature that exists out there, on aerobic exercise, there's a bit of a mixed bag of findings, but there's, for example, a Hoffman paper found there was no change in sensitivity to pain when exercising at 50% VO2 max. And then a Norgel et al. Meta-analysis showed that basically the higher the intensity, the larger the effect, and the actual, in studies that did report a change with low intensity aerobic exercise, pain sensitivity with really small effect. So basically the consensus from the general aerobic literature is that anything below 50% VO2 max doesn't really have an effect on pain. So we saw that within our study as well, which is nice. But obviously the part we're most interested in is that when we had performed that same exercise but with blood flow restriction, we saw an increase in pressure pain thresholds in the legs. Now, obviously, the difference between this paper and the previous study is that we did bilateral BFR in this because they were cycling, whereas in the resistance exercise paper, we were just exercising, they were just doing leg press with one lower limb. So essentially, if we try to summarize it as simple as possible, when we added the BFR to low intensity aerobic exercise, it causes hyperalgesia in the exercise and limbs. And the magnitude of that change with BFR applied at 40% limb occlusion pressure was comparable to high intensity exercise. And then what we also saw similar to the previous paper is that we got remote hyperalgesia as well in different areas of the body. So it's just kind of the second time we found systemic hyperalgesia with the BFR exercise, which is nice as well.
Did you do 24-hour? I forgot to look at that.
This paper, we didn't do 24 hours, no.
Okay.
Yeah, we did in the previous resistance exercise study. That's something we're going to potentially be looking at in the near future, because I think, that was a particularly interesting finding previously, because, exercise-induced hyperalgesia typically lasts for 45 minutes to an hour. I'm not aware of any evidence of it lasting longer. And it'd be really interesting to see if we can A, replicate the resistance exercise findings again, and B, if aerobic exercise has the same impact as well.
Yeah. Anecdotally, I've had some patients come back the next day and said they still felt like they had less pain. I mean, you never know with pain ratings, but yeah. So, and 80% better effect than 40% as well. So high pressure.
Yeah, exactly. And that replicated what we saw with the resistance exercise as well. So a higher pressure resulted in greater reduction in sensitivity to a painful stimulus. So, I mean, that's now two different data sets that have shown this. So it's really kind of, to me, it's pointing to the fact that there's some effect of pressure. I don't know how yet or what, but it's obviously having some kind of an impact on the magnitude of this effect. And it kind of makes sense as well when you look at some of the existing papers out there. So not just our own ACL work, but to use that as an example, because obviously I know that pretty well. We were seeing that acutely in the training study that, and over time, the 80% LLP BFR protocol was resulting in greater reduction in pain in a high intensity exercise group. So it kind of, what we found in these acute studies in the healthy populations is kind of reflecting what we saw in an ACL patient population, which is interesting.
Yeah.
And I think I have this right, Luke. The magnitude of the endogenous opioid release or beta endorphin was greater in your high pressure group than in the other two groups, was it not?
You mean for this particular study?
For this study, yeah.
I think it was comparable between the BFR exercise groups. Just pulling up the table here now.
I think it was beta endorphins were comparable, but I think the endogenous opiates were
You mean
greater
the endocannabinoids.
in the high
Endocannabinoids.
or the endocannabinoids were higher.
Yeah, that was higher in that high intensity cycling group, right? It was substantially higher.
That in the BFR group at high pressure. Both the high pressure and the 70% VO2 max group were higher than low intensity and 40% LOP.
Yeah, so that the blood findings were particularly interesting because I'm sure you can see that we found something like complete opposite to what we hypothesized, because that first resistance exercise paper we basically found beta endorphin increased. There was a big spike with both BFR conditions and no real change in the other exercise conditions. And then we didn't see the endocannabinoid marker we chose 2AG without saying the full word. There was no change in that whatsoever. So we hypothesized that maybe beta endorphin within the opioid system is a big driver of what we're seeing with BFR, or at least a contributor. And then obviously, as you guys know from this paper, when we did it, we actually saw changes in 2AG as well with BFR exercise. And as Kyle pointed out, the biggest change in that marker was with the high intensity exercise group. So what's really interesting here, and I was thinking about how we could write this paper and how we explain the findings. It's why is resistance exercise with BFR led to a big spike in an opioid and not an endocannabinoid, whereas when we've done aerobic exercise with BFR, it's led to a spike in both. And if you look at some of the existing aerobic exercise literature, some non-BFR related stuff now, there's evidence to suggest that the type of exercise can influence what type of endogenous pain inhibition system you activate, but also the intensity and the duration. And if you compare those two studies, the first study we did 5 to 6 minutes of an acute resistance exercise protocol versus 20 minutes of cycling here. So that could be potentially why we've seen different changes in blood markers in some respect.
Yeah. Much longer duration of hypoxia for sure.
Yeah. But I think
so.
Sorry, John.
Go ahead. Well, no, initially we were looking, beta endorphin just made total sense too, because it seemed to be driven by lactate. And lactate's pretty easy to make happen when we do BFR. So I don't know the 2AG. I mean, do we know kind of like what upregulates it? Is there this conditioned kind of response from just the tourniquet itself, or the pain?
Potentially, yeah. Potentially, yeah. I mean, it's difficult because obviously we're just measuring something in the blood doesn't necessarily mean cause and effect, but it's interesting to see that. And I think, look, as you guys are aware, we're doing a couple of follow-up studies here now to really dig into the mechanisms a bit deeper. But I think one thing we're going to do, no matter which mechanisms we're looking at, we're going to keep repeating these blood markers if we have enough money to do that, so we can really get a bit of an idea across a group of studies, and then try and figure out exactly what parameters of exercise that the BFR exercise might be influencing this. So there's an argument for doing a bigger range of pressures. There's an argument for doing different intensities or different low intensities of exercise with the same pressure, and trying to tease out what exactly about the protocol may be eliciting either opioid or endocannabinoid mediated mechanism.
It's pretty cool from a athlete's kind of perspective as well, because I think a lot of the teams we work with, they have their players do BFR after the games or after practice to try and recovery, or maybe there's some analgesia. But it's much easier to do intervals on a bike, I would think, especially if you're pretty smoked after a game versus go get on a leg press or something like that. And if we can say that this potentially spikes these two systems of pain relief, I think that's pretty powerful.
Yeah, agreed. And I think if you look at the magnitude of, I think it's important to note that we've only measured pain sensitivity with one type of noxious stimulus. So I suppose, the next step would be to include like a battery of tests for that to get a better picture. But
like a car battery, like you make them like actually really hurt them, like shock them.
Yeah, I think we'd struggle getting that through ethics, but yeah, we can give that a go. But I think, what is important here, because I've already had a few questions from people via email, just like, resistance or aerobic, what would you do? What would you recommend to reduce pain with BFR? And I think actually, if you look at like the magnitude of the decrease in pain sensitivity, they're actually quite comparable. I think what you said then, Johnny, is right. So it's what's more applicable to the situation you're in. If you've got someone really early, like post-surgery, like post-ACL surgery, and a really swollen, aggravated knee, then maybe doing low intensity cycling might be easier, as long as they've got the range of motion to do it. So, but for me, the most important, most interesting outcome from this and conclusion was that, we showed that by doing the exact same exercise, but with BFR, we had this effect not only in the exercise and limbs, but also systemically. And to dig into the data a little bit deeper, in this study, we found that low pressure BFR at 40% limb occlusion pressure didn't really have an effect on these remote areas of the body. But whereas 80% LOP did. So again, it's another indication that pressure might be really important for this effect, because we didn't see 40% have an effect elsewhere in the body, but 80% did. So
that was something Jeremy said on our podcast a couple of times ago too, was that Jeremy Lineke's, that they had seen that as well in their studies, these kind of remote reductions in pain, this kind of systemic effect, if you will.
Jeremy even said it's the only time he's going to use systemic with BFR.
I know. I backed him into a corner on that one. It was funny. I was like, dang.
Yeah, but he said, this looks like something that truly has a systemic effect.
Yeah.
Yeah. When looking at the upper trap, it was only that high pressure group that had a significant increase.
Yeah.
No other group did.
Yeah, increase. And by the way, I mean, it was a decrease in pain. They tolerated an
they had a higher
increase
in
important
pressure pain threshold.
That we make that point, because it gets confusing reading these papers. It keeps saying increasing, and I'm like, okay, but I have to keep reminding myself that we're talking about decreased pain.
No, definitely.
Increase in pain pressure threshold.
I think that whole systemic effect with exercise induced hypoalgesia is quite, I was, to be honest, when I first started reading around that literature, I was quite skeptical. But then I was really surprised by the size of the body of evidence around that. And what you tend to see when you're doing unilateral exercise is that the effect's greatest in the exercise and then we get it, in the contralateral limb and remote areas of the body, but at a smaller magnitude. And that's what we've seen across these two studies here as well. So that's quite nice, because it kind of makes us a bit more confident that what we're seeing mimics what we should expect to see with exercise-induced hypoalgesia by itself. And it's really interesting then to think about how, if BFRs not only having a greater effect in that limb, it's causing some kind of local physiological changes. There's also some going on systemically as well. Which that would suggest that it's some kind of spinal, supraspinal involvement that we need to figure out exactly.
Yeah, going back to your last paper, and Jeremy wrote a really nice review pain paper. What he mentioned as well is that sustained hyperalgesia, 24 hours later, didn't correlate to what you saw on the opioid release. So there was an opioid upregulation the next day, but the pain was still down. So there's probably is this other pathway we're missing. Yeah,
absolutely, and that that. For me, when we found the elevation at 24 hours, that was really surprising, because kind of, we hypothesized, we saw that the change in the opioids and beta endorphin mediated the relationship between, an exercise intervention and change in pressure pain threshold. But as you said, they were back to baseline levels at 24-hour post exercise, which wasn't surprising. Mm-hmm. And then, everything else we thought might be potential mechanisms, such as the discomfort generated during the exercise. We wouldn't expect it to be any discomfort at 24 hours. So again, there was, although that's really good clinically, we have no real idea how to explain it yet. And
right.
Yeah, that's going to be interesting to try and figure that out later date. One thing I did think is is it just because there's some swelling left over? So, obviously we get cell swelling with the BFR. And I have considered recently, could that potentially have an influence on the pain measurements post-exercise? Because obviously, if we're using a mechanical pressure stimulus and we're pressing on that area of the muscle that's now become swollen, could that potentially influence their perception of discomfort from that? But at 24 hours post-exercise, we wouldn't expect there to be any swelling left over. So, that's when we thought. Yeah, it's just something. I think that's something that I've thought of myself, chatted with Stephen about, and I think it's something we're going to try and measure acutely in upcoming studies as well. But again, saying that, we're also seeing changes in pressure pain thresholds in areas of the body that haven't exercised and wouldn't have any cellular swelling around there. So
right, like everything, multifactorial.
Yep.
What about how long the endogenous or the beta endorphins remain bound to the receptor. So so beta endorphins go down, but then what about what is already bound to that mu receptor? How long does it stay bound? And then kind of, I don't know what the half-life is or what have you. Could that have some sort of sustained effect as well? I don't know.
So you wouldn't measure it because it's bound, because it's not in the blood anymore.
Exactly. So what is left over from what has been produced is already kind of taken up or back down to normal. But then how long of an effect is what is bound to the receptor? How long does that have?
Yeah, it's a great question, Zach. And to be honest, the easy and short answer is I don't know. And that's something that we're going to have to try and figure out. I'm not aware of any, at least I haven't come across any beta endorphin literature that can give information on the half-life of that. I think one thing that I want to do in the next study to really tease out, the importance of beta endorphin, because we've shown twice now that it's gone up with exercise. So it's obviously partly contributing at least. But I think the next step would be to use like a beta endorphin antagonist, so like something like naloxone, and inject it and include different trials. And then if we see that, if we inject a beta endorphin antagonist or inhibitor, and then we don't see this exercise-induced hyperalgesia with BFR, then that gives us, a whole new look at or whole new support for the role of that.
It's kind of like Rasmussen's group using rapamycin to prove mTOR.
That'd help answer that 24-hour question that Zach had too, then, if they did that, because if you don't have it immediately after, you're not going to have it 24 hours later.
They did that with rodents, and that was one of the remote IPC studies that was done, looking at the effect of on the heart, like cardiac tissue. Pretty much with that, Luke, and that's where they found like IPC does activate these opiate receptors. So literally, just the use of a tourniquet or occluding blood flow outside of exercise does have an effect on the opiate receptors. But then like it's a matter of a carryover, then what kind of analgesic effect do you get from there? And that was kind of really the premise of Jamie Burr's paper,
which we can roll into. So that's the next question. So Luke, you've really eloquently have shown us that BFR with exercise activates the opioid system, the potential endocannabinoids, and you get this pain response from it. So then the question is, do you have to exercise? Can you just use an IPC protocol, which is much easier if you're doing this like on an athlete or early post-op? And there is literature out there pre-total knee, I forgot what it was. I think it was like gallbladder removal. Which I had my gallbladder removed years ago. That sucks, man. I wish I would have tried this. They swell you up to do it. Like like they put a gas in you and swell you up to take it out. And then you get done. Yeah, they got to pump your trunk all full because to have enough room to see in there, I guess. I don't know. I didn't do the surgery, Kyle. And so anyways, you get done.
Maybe you'd be number one on Google.
Why not, Johnny?
But he's like, man, when you get done, it's going to feel like you have an elephant on your chest because of all that pressure. And then that air has to somehow move out of your body. So you just fart like just like a madman. I'm just apologizing left and right to the nurses. Like, oh my God, I'm sorry. Like, anyways, if you put the tourniquets on pre those surgeries, it seemed to have a reduction in opioid use as well as pain post-operatively. So that was what I think Jamie was looking at with his IPC paper. Healthy model again. Can you just put someone's hand in it was 1 degree Celsius ice bath, which what is that, like negative 400 degrees Fahrenheit? I don't know the metric system or.
No idea. It's right around freezing, like zero.
It's around freezing.
Is it Wales in the winter?
Zero is 32. That's zero is freezing.
Okay. Well, good.
Yeah, there you go.
Jesus, way to make us look stupid, Zach.
Yeah.
All right. And so,
that's why I stayed quiet. I didn't know anything.
Fourfold increase, Kyle over there.
Oh, geez, fourfold. So
Here we go.
Put their hand in this cold ass water, and then see how high their pain intensity gets in it. And once they take their hand out, how long it took them to have that pain go away. So they say pain when their hand's in the water, and then when they took their hand out, they say no pain, and they see how long that time was. Then they did on their arm an IPC protocol. He used Delphi's 100% LOP, so the same 100% occlusion, and then put their hand back in the ice water to see, did it reduce the pain intensity and how long they had pain. And if they use IPC, the intensity was still bad, but their total time with pain was less. And then what he wanted to also look at is, because we know with the IPC literature, there's responders and non-responders for athletic performance. And he wanted to see if you had a better pain reduction, does that just mean you're a good responder to IPC? And if you did a time trial test and did IPC before, you would perform better. And what they found was there wasn't correlation between pain as well as performance. So we can't say that, but what they can say after this one is IPC reduces your total time with pain if you're under a painful stimulus. So
in Jamie's paper, Johnny, I believe I have this right, it took longer for the pain to come on.
No, it was pretty much about the same.
Or it went away faster.
It went away faster.
That's right. Yep.
Yeah.
It was interesting how they do it. And I wondered if this was one of the possible limitations, was they just did 2 minutes. They didn't do it to like max tolerance. It's almost as if they reached a ceiling effect. And there was really it was a slight increase in pain. I think it was around a 2 on the pain scale at 15 minutes, and then went up to, basically peaked at around 30 minutes, or it peaked at 3 or just over 3 or something like that. And then it just stayed there. So I wonder if they would have just left the hand in there until they reached a tolerance, if that wouldn't have conveyed more of a response on the time it took to get rid of the pain.
Yeah, that's a good point.
And so
their total time of pain was a pretty big response, though. Like their Cohen's was like 1.3 or something.
It was.
So it was a big response.
Yeah, 1.3 was huge. And then, but yeah, I just wonder that when I was reading that, because everybody did 2 minutes, and they said like everyone tolerated 2 minutes. And I know, some of the military stuff is literally cold water is a beast. And that's really where kind of people quit and decide not to do things anymore. So I wonder if the hand was in cold water for longer than 2 minutes, or if they did a larger body area where the pain and kind of the tolerance would have been really tested, if we would have seen a greater change. And then on the performance side, what was nice was these folks were more aerobically trained. I think VO2 maxes of the males was at 63 and females was around 55. And there was, I think, an 11-second improvement in their 5K time trial, cycling time trial, which doesn't necessarily sound like a lot, but for an aerobically trained individual, cycling on an all-out time trial at 11 seconds is pretty huge. Luke, you probably know that, like over in Europe, like with the Tour de France and stuff like that, man, 11 seconds is a massive improvement on the time trial.
Yeah, definitely.
Yeah, but once again, responders and non-responders there too.
Yep.
Right.
Yeah.
So that's what's interesting,
63% or 8 of the 13, I think, were considered responders. And then what was weird too was, like, just like you said, you have non-responders, and by like non-responders, it's not like they just only improved like a second or so. No, there was a drop off in performance. They got worse in those 5. So
that's what we say, if you're going to do IPC for performance, you better practice it first to see who you're dealing with, because you could have a pissed off athlete if they're feeling sluggish for some reason. So what are your thoughts, Luke, from an IPC protocol versus exercise?
Well, just before that, John, I wanted to just go back to something Zach said that I think that I've been thinking about a bit recently, with the whole, if they'd have left the hand in a bit longer and just measured kind of, maximal tolerable intensity. And that's something that obviously we haven't done in our 2 BFR papers so far with pain. We've just looked at pressure pain threshold, which is kind of the point at which a stimulus becomes painful. We haven't looked at pain tolerance and gone above that. And I think that's something that's really important for BFR. And I think one of the ways we talk about using BFR, and I was up with the UK military last week for you guys doing a training session, and
you have
one of the things which, pardon,
in the UK, you have a military.
That was what. That's. I'm pretty certain that's what. Like. You talking about the Welsh? Or the Brits in general.
What are we talking about here, Luke?
We see the Welsh. We see ourselves as a separate nation to the UK, especially with some of the decisions that are made down here. But anyway, we won't get into that. But one of the big topics of discussion at the rehab centre was, this idea of this acute hyperalgesia and how it potentially could be used to allow greater loading. So I was talking a bit about if you have someone with a painful tendinopathy, and it's kind of going back to Karakakis for the first paper where it looked at acute hyperalgesia. It's like, if we can acutely reduce pain, that's great, but that can then for pathologies that really need to be loaded, can that allow them to tolerate more load? And I actually think that's an important angle on the BFR and hyperalgesia that we haven't looked at in our two studies. So it's like, okay, great, if it increases pain thresholds, it increases, or saying Cal going back to this increase decrease, but basically if a stimulus doesn't become painful for a little bit longer, but also arguably does it also increase tolerance of the stimulus as well? Because that's really important, because if pressure pain thresholds didn't change, for example, but how long they could tolerate it after did increase as a result of BFR, then that's also really important as well. If you wanted to do something like, can they then tolerate more load in a rehab setting? That's something I just was thinking of recently and thought, that's potentially, we should add that into future studies ourselves and anyone else, any other groups who are doing that. So not only looking at thresholds, but tolerance.
I think being able to use this as a means of reducing people's pain clinically, it can be very powerful simply for the fact that sometimes the pain that people are having very early on, like post-op, like once you can tamp that down, it just kind of stays gone. It doesn't necessarily pop up. Some of that is just, a little bit of fear. There's a lot of different variables kind of factoring into why this person is hurting. And so the ability to do that is a pretty important thing for a clinic setting. And I know I've had experiences, Zach and Johnny, I'm sure have as well, where you're able to actually knock a patient's pain down with kind of a simple little thing and doesn't necessarily return. That's a big win. That patient comes back and that patient tells their friends too. So,
yeah. I think the one thing, we've said it in these papers, I'm very quick to write, this could, be used as a pain management tool, and of course it could. And the next big step really is even just repeating these two studies we've done in a chronic pain population and looking at, is it the same? Now there's evidence from our own ACL stuff and other kind of clinical populations that have been done, the NEOAs, anterior knee pain. There's a lot of evidence so far in the early stages to suggest that yes, it will. But it's having a look at this acute response, because I'm sure you guys are well aware, sometimes exercise in chronic pain populations gives them hyperalgesia. So it's like, looking at different types of chronic pain populations and trying to see, which ones may benefit the most from it. And potentially there's some guys out there, just like you get like responders, non-responders of IPC, potentially there's some people out there who wouldn't benefit from BFR on them.
And that's where, looking at this from a programming perspective, they put out in the Karakakis paper, maybe do BFR first in your treatment progressions if you're going to potentially have this hyperalgesia for a while afterwards.
Yeah, I think it's really exciting because we're at like such an early stage of this. Mm-hmm. It's nice that we have these two data sets now from our stuff out of our lab, looking at potential mechanisms, but there's so little we understand about it. And it's like, I think there's a good bit of evidence now to suggest that pressure's influencing it. So, it's then what you were saying when we move on to Jamie Bird's paper, do you need exercise? Can you just get away with just pressure as well? So I think that's.
Well, this is, it's what's awesome. It's kind of like with BFR in general, it's like, okay, yes, it beats low load. It does this for strength and hypertrophy. And then you muscle phys guys came in and explained all the mechanisms, we don't know them all, but it's like, well, it does this, it does this, it does this. So this makes sense. And now we've got, from a pain perspective, we kept seeing reduction in pain. And now it's like, okay, these are the mechanisms behind it, because pain is important for our insurance payers. And if we're showing that we're objectively improving the limb, but also reducing pain and potential opioids, that's a huge, huge clinical win.
Definitely. And I think, there's also the question I've been asked of, could this potentially reduce a patient or an athlete's reliance on taking pain medication? And I know, Johnny, we spoke about this in the past. That would also be huge as well. If you could use BFR, and even more so if you could have a patient in a bed, who can't do any kind of exercise, and we just put a cuff on and perform IPC. If that potentially can modulate their pain, then that would be pretty amazing.
Yeah. Speaking of military, are you involved with Pete Ladlow's study, that big multi-center they're doing, Luke?
I'm not involved in the study itself, but I was up there last week just doing some BFR training with them and discussing the ideas. But they're planning a really big study, and we had a good chat about some other potential avenues for research as well. So I think it'll be really nice to see some more BFR research coming out of there, hopefully.
Yeah, awesome. Well, any last thoughts, you guys, on analgesia, Luke's paper, IPC?
The one thing I was going to say that was different between the Jamie Burr IPC paper and the two surgical, the total knee and the gallbladder surgery, was the total knee papers were done in the lower extremity, and Jamie did his in the upper extremity. Mm-hmm. And it makes you wonder, maybe they both were at full occlusion, or they all were at full occlusion. But it makes you wonder, is there a volume of blood flow that's being occluded, or the amount of tissue that is hypoxic?
Yeah.
Does that have a role in conveying the IPC response?
The gallbladder one was lower extremity as well?
I believe so. Yeah,
it was. Yeah. But the interesting thing about both of those papers was then the gallbladder one, they did like partial exsanguination before they applied the tourniquet. In the total knee, they fully exsanguinated the limb before they ever did the IPC. So, I think you have to kind of wonder, like, well, if you had actually allowed the limb to reperfuse for that 5 minutes and then done the exsanguination, what would the response have been? Would that have mediated it in some way? So I think there's some pretty big limitations to both those IPC surgical papers from that perspective. That's one of the common things in all the IPC stuff is this kind of 1-to-1 ratio, inflate, deflate. So I think there's a lot of space there for anybody that's listening that wants to do a study and look at pain and IPC postoperatively. There's some room for sure.
You heard him say he needs the money, man. He needs money, honey, to make this happen.
And then Kyle, with that too, was they only did one cycle.
Correct.
Right. So versus all
there's
the
a lot
other,
of space there.
Yeah, a lot of the Salvador systematic review that was basically like you need more than one cycle to, at least from the performance or to have the effect. And then 3 seemed to have the best, and that's what we've decided to go with. But yeah,
I suppose that kind of highlights 2 key things really that in the BFR and pain research moving forward that we need to identify. It's the time course response. Looking back at 24 hours again, is it longer than 24 hours? It could be. We didn't measure any further, so it could be 48 hours for all we know. And then it's also, what's the minimal effective dose? How little can we get away with in people who are really debilitated or really early post-op as well? Mm-hmm. So lots to be done.
Well,
can we just sum up basically kind of like what we covered like a little bit? Because I think it was a little bit more jumbled than sometimes always. We weren't real linear with our discussions. In particular, if we could kind of sum up maybe what Luke and your studies have shown regarding magnitude of pain reduction and what matters, beta endorphin, 2AG, that kind of thing.
Yeah, sure.
I'll just put that on you, Luke, to do that.
Yeah, sure. So essentially, we've shown now for the second time that adding blood flow restriction to a form of low intensity exercise increases hypoalgesia effect. And actually, in this particular aerobic study, just performing the low intensity exercise alone was not enough to alter pain sensitivity. But when we performed BFR during the cycling and inflating and deflating the cuff over 20 minutes, we were able to have a positive effect on pain sensitivity and reduce sensitivity to noxious stimulus. We also found that, again, for the second time, that there was a greater effect in the exercising limbs with a higher percentage of LOP used during exercise. So suggesting that the pressure itself is having some kind of an impact. And then we also found in this study that beta endorphin increased with both the BFR exercise conditions, and also so did 2-AG and endocannabinoid as well. So kind of second bit of evidence showing beta endorphins changing as a result of BFR exercise, and this might be having an influence on pain.
Beautiful.
And the 2AG seems like, yeah, I did. I wanted to ask one more question because I think we hit it, but maybe not thoroughly, only because it's kind of a question in my head. But it seems as though the duration of the exercise might be kind of this mediator for 2AG. Yeah,
potentially. So the available non-BFR literature out there suggests that type of exercise, the intensity, and the duration, by altering these parameters, you can elicit either opioid or endocannabinoid mediated hyperalgesia. So even using the same form of exercise, so say we just picked resistance as an example, the intensity and duration of that same exercise can elicit either opioid or endocannabinoid mediated hyperalgesia. So it's really interesting because, even in that literature that's been going on for 20, 25, 30 years, they still don't really know exactly, what's the optimal or what type of exercise parameters are listed either. But it's clear there is a difference.
Yeah. Cool. Okay, I'm good now.
Ben, do you have any questions?
Oh, Ben, are you there?
That's right.
Ben's got a question about Keeley from Ted Lasso.
Ben's just. I've got this feeling that Ben's just in the shadows, just watching his questions unfold without taking part.
He's the Wizard of Oz. He's behind the curtain.
Well, cool, Luke. Thanks for another great paper. We'll also point out that you also have a review paper on BFR's use in space. If anyone doesn't know, Luke is secretly wants to be an astronaut. Is that what y'all call them in England? Astronauts as well? You have a weird term, like a astromate.
How do you pronounce it? Is there a weird way?
We pronounce it the correct way, just like football. But yeah, astronauts.
Anyways, it's man, you guys really do a great job with just summing up how BFR works. So anyone that man, it's mechanistically spot on. Kyle Hackney and Stephen were also on it as well. So three strong minds at it. So that's another good one to check out, not only for applications in space, but also understanding just how BFR works. So Luke, any other projects you want to talk about before we break off?
I think no. I think the key thing, really, I suppose, is just that to keep going with this stuff. We got so many questions to answer, as we just pointed out. I think we've come out of the podcast with more questions than we came in. But it's now replicating this stuff in chronic pain populations, and also trying to optimize it as well.
Awesome, man. Thanks for your time, brother. Go play some football now. We know you got a big game tonight. So.
Practice? We're talking about practice, Luke?
Practice, training, yeah.
Yeah, training. Come on the pitch, Kyle.
You've got to train to get to number one on Google, because what I didn't tell you at the beginning of the podcast, so I didn't have to take stick for it or thing, is I've also Googled my name, and I come and I've got
stick. Take stick.
Where you at?
There's a baseball player above me, called famous baseball player called Luke Hughes. I'd never heard of before.
Did he have a strong skull? Is he still alive?
Yeah, strong skull. Yeah.
I've never heard of Luke Hughes, the baseball player. Cool, man. Well, see, is he above you? He took you out?
Yeah, he's way. No, I'm so far down. I'm on like page 3, Johnny. I'm nowhere.
All right.
Not as good as you.
We got to get your following going, man.
People haven't been clicking on that weird biopic of yours, Luke.
All my pictures are weird. Sticking in front of the camera and it goes down badly.
All right, fellas. Thanks, Luke. Right. Appreciate it as always. Ready to have you on when the next paper comes out.
Thanks, Luke.
Thanks, guys.
Thanks,
been fun as always.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.